Yeah, sorry about that. Hi everyone, and welcome to Endometriosis, Moving Towards a Pain-Free Future. I hope you'll notice I went to great lengths to organise our panel here in an aesthetically pleasing colour palette. I've also tried to cluster them according to their areas of expertise and interest, and most importantly, so it gives a bit of a clue as to their usefulness for you, for your particular questions, concerns or comments, which tonight is really all about. It's a public forum. We're lucky that there's a symposium going on in Melbourne right now, which has brought a lot of experts in endometriosis, a lot of consumers, a lot of people who are really driven in this field together. So this is the opportunity for you to really get your questions answered and your concerns aired with the people who are not just working on the agenda, they are setting the agenda. My name's Bernie Hobbs, and I'm really delighted, a little bit terrified actually, to be the chair here tonight, because I do a lot of this kind of thing, chairing sciencey things and medical things and all sorts of things. I have to say I've never felt less qualified to chair a debate in my life than I do right now. I am one of the 90-odd% of women who has had trouble-free periods all my life. So, and my experience of endo was knowing a friend who had it and who had really painful periods. And that was it until I spoke with Caroline a week ago and she was giving me the background on it. That is a disgusting situation because I'm a bloody science reporter and I should have been writing about this, I should have known about this, but this is a silent pandemic in this nation, and that's something that has to change. And I know that if Donna Chicha has anything to do with it, that is damn well going to change, and with her able compatriots along on either side here, there's a lot of work being done. I guess as someone who could only be less qualified to be here if she was in fact a white middle-class man, and generally that is who's doing these kind of forums. It's really important for me that we get the facts out right from the start and that everyone gets a chance to have a say. Speaking of white middle-class man chairing panels, it is a bit like Q&A, except you'll notice that we've got 8 panellists, and I don't think Tony Jones himself has ever approached quite that number, so it's pretty stellar. And we also don't have any politicians, so everyone on the panel has something of value to say here tonight. It's a big issue. The second 2/3 of this evening is going to be all over to you to put your questions to our experts. The first half hour is just getting some of the latest findings and aspirations in this field out there, and then you can respond to them in that second section. If I can just explain the clustering here, on my far left, on the far right of the stadium, of the stand here, we have got our gynaecologist surgeons and our gynaecologist. If I can just start with Luke at the very far end. If you're thinking gynecology surgeon, that's Luke. Can you just do yep, thanks. Next to Luke, we've got Andrew Horn, who's a gynaecologist, pain, not surgery, no cutting, just pain, gynaecologist surgery. Is that correct, Luke? Andrew? Oh, a bit of surgery. It's not what you said when I asked you for your bio a minute ago. So Louise Hull. So Luke is here in Melbourne. Andrew has come in from Edinburgh. Louise Hull is gynaecologist, pain and adolescence, no surgery, and also research. So does a lot of clinical and basic science research as well. Not to make you other two seem like slackers, but her list is a bit longer. So there's our... Oh, and fertility. Sorry. Who does fertility? You. Okay. That's how it works in the medical world. It's all about the one-upmanship. No. Okay, so there's our clinicians down in the far end there. Okay, at this end closest to me, we've got research scientists just pouring herself a drink of water, 8 glasses a day, very healthy approach. Caroline heads up the endometriosis research group at the Ritchie Centre, which is part of the Hudson Institute. The Hudson and Ritchie together are putting this event on tonight. I have to say that because all of the beautiful marketing that went into the slides is now hidden behind our panel on the display. So Caroline is pretty well responsible for bringing this event together tonight, and Caroline, don't blame her, and Caroline's work is in trying to understand the causes, like really looking at the actual causes of endo in the human, well, and in bodies. Gemma, next to Caroline, is working on an early diagnostic, which would be something pretty wonderful. And right in the middle, centre stage, as they should be, are people who are living with endometriosis and have some fairly appalling stories to tell. So if we can just kind of get the temperature of the room a bit, obviously not me because I'm now having a hot flush, just to top everything off. If we could I just ask you, if you're happy to, if you have endometriosis, just to put your hand up. Okay, so it's not a completely representative sample of the Australian population, but it's a sample who very much know the situation. Can I ask you if, because according to the statistics, it can take 7 or 8 years before you are diagnosed. Was anyone more than 7 years before they were diagnosed? Was anyone more than 10 years before they were diagnosed? 15 years? We have got a very, very serious problem when you look at the ages of people here who have struggled for a very long time without being diagnosed. Angela in black here is... why are you looking at me like that? Did I get your name wrong? No. Angela Farley is not just a woman who's lived with endometriosis for 20 years. Would that be right? Yeah. She's got. You could do the real checklist. I won't ask everyone to go through this, but could you? You have had all of the treatments you can have. You were on the pill in your 20s.
15.
From the age of 15. There's actually a microphone there. Sorry. You had a Mirena.
Yes, so I started on the pill when I was 15, and then after my first surgery I had the Mirena.
Okay, did the pill, how was that in terms of reducing, what were your main symptoms?
Pain.
Pain. How did the pill have any effect?
In between.
In between. Did it have any side effects?
Yes, anxiety.
Anxiety. Weight gain? Weight gain.
Yeah.
You gained 20 kilograms?
Yes, after the Mirena.
Oh, after the Mirena. Okay. So you've had the hormonal treatment. You've had surgery. So you had an excision.
Yes.
And
most recently I had a hysterectomy, but that was for adenomyosis.
Right. So the hysterectomy was not related to, or not, certainly not as a treatment for endometriosis. Correct. Which I have to say, one of the other things that I was under the misbelief of was that hysterectomy was in fact a treatment for it. So you've gone the whole gamut. You've had the hormone treatment, you've been having pain treatment, you've had surgery a couple of times. Mm-hmm. Are you living with pain now?
Yes.
Are there any other places to turn?
I have a pain specialist who, so that's nerve damage, that's more medication, psychologist for the mental, I suppose, drain that puts on you for being in pain for so long. acupuncturists, dietitians, occupational therapists.
Right.
I think that's it.
Oh, you think
Maybe.
that's it? Yeah. When I spoke to you about this, I think yesterday or the day before, and you were telling me your story, I couldn't believe it. We can't go through it because it took half an hour to detail everything. When you were telling me your story, as each stage got progressively worse, and then I said, "Oh, you must have one of the worst cases there are," and you said, "Oh no, I'm one of the lucky ones."
Yes, correct. I believe I'm lucky because my second surgery was with an excision specialist, but I know that there are many women who haven't had that opportunity and have had 5 to 10 or more surgeries. So I believe I'm lucky because I've had a bowel resection, but I know that I'm done, hopefully, with surgeries now.
And in terms of pain management, what sort of level is it at now?
Currently, I'm still on opiates for pain management and gabapentin, which is for the nerve control, but because my hysterectomy was only not quite 9 weeks ago, I'll be back to see the pain specialist after the 3 months. So hopefully after that it's all up from there with pain management.
Okay, so is this kind of story, so Angela, you feel that you're not outstanding in this, or this isn't a particularly bad situation. From the people who see patients with endometriosis, is Angela's case history, is that abnormal, or is it a real outlier, or is it reasonably common?
I think
It's off.
Might have to turn it on. Yep.
So as you said, endometriosis is unfortunately very common. As specialists, we probably see the worst cases in sort of tertiary centres where we work. But there are a number of women who experience similar or worse symptoms, and one of the major problems is we don't have a cure for endometriosis, so we're left with managing it either by surgery, hormones, or treatments like gabapentin. So unfortunately, yes, it's not uncommon we see people like this.
So it's a pretty dire sort of situation. Can I just ask one more time, if you in the audience have a similar sort of case history to what we've heard from Angela here this evening? It honestly beggars belief. I cannot believe that this is such an under-known situation in Australia and apparently globally. Now, Andrew, I know that you are part of a group, and Caroline, you're part of that group as well, I think, who put together these 10 research questions that the global community of people working towards better treatment, understanding, diagnosis of endometriosis, they've just sort of gotten together and made this list. Can you tell us a bit about what was behind that list?
So one of the points that you've alluded to is that unfortunately endometriosis research is underfunded, so it's really important that we use the limited funds that we have available appropriately. So as a community, in the UK to start with, we decided to try and identify research priorities that weren't just important to us as researchers, but were important to patients with endometriosis and also to the clinicians who see them from day to day and who treat them. So we set about an exercise whereby we first of all launched an open survey to ask patients and clinicians to submit what they thought were the important unanswered questions about endometriosis. And then as part of that process, we then sort of, if you like, edited down these questions because we received nearly 5,000 questions. Some of these questions were repeats, and so we were able to amalgamate them into shorter summary questions. And then we launched a second survey where we asked patients and clinicians to then rank them. That then generated a list of 30 questions, which we took to a day-long workshop where we invited patients and clinicians to again further try and reduce this list down to a top 10 list of research priorities. So that's how they came about.
So these 10 research questions, they are really, I guess, driving or at least shaping the research agenda, what's happening, what's likely to be the focus and hopefully funded globally in endometriosis research?
I hope so. I mean, the first objective of the exercise was to generate that list, but the other objectives that our group had were to publicise them. So we published them in what we call high-impact journals. We got press attention, so the whole list was actually published in the Sun newspaper in the UK. And then we also invited...
It's not exactly Nature, but it's still a win.
No.
And in fact, it's much better because it's got a much broader readership.
A much big population. And then we invited funders to come to the meeting, and then we've had subsequently meetings from funders, and they're proposing to launch themed calls within the UK for some of the questions. We also took them to the World Endometriosis Society, which Luke is about to chair in a couple of years' time, and they, every 3 years, produce a list of research recommendations, and they're going to be used to sort of inform that list in the future.
Great. Okay. So how we're going to run tonight in this first half is we've got these 10 questions, and they are called research questions, but they're actually really accessible and hopefully really covering a lot of what you want to know yourselves anyway. Once we've gone through those 10 questions with our panel, various people jumping in on each of them, then it's completely open forum for you to please put your questions to our experts here tonight. So I've rearranged the order a bit after all that consultation that you did. But the first research priority that we're going to look at is what are the causes of endometriosis. And what I would like to know there, and I think Louise and Caroline, you're probably the best positioned people to speak to that. What do we know right now? What's the latest research telling us about the causes of endometriosis?
Well, I think one of the things that we really don't understand is why some people get endometriosis but other people don't. And we all want to find what the cause is so we could be able to identify people who might get it and help them get a diagnosis and treatment more quickly and more effectively. And a lot of research has been done to try and work out why people get endometriosis. We have a lot of theories, and probably the best theory is that when you have a period and the tissue comes out of your body, some of the tissue does go up through the fallopian tubes into your pelvis, and it's your own tissue, so your own body can then heal it and not clear it. And then what happens with that tissue is it responds to the hormones in a cyclical way, and then regrows and breaks down, and it causes some inflammation in the pelvis, and it gives you symptoms of bloating and pain and all the other symptoms that people get and I'm sure other people can explain them better than I can. And we think that's probably one of the underlying reasons, but a lot of people do get that tissue going into their pelvis and don't get endo. So there are a lot of other factors that we don't understand. And we know that there's some genetic reasons, there are probably environmental factors that impact, medications may change things, hormones certainly can appear to make a difference as well. And Caroline's probably got a lot of other factors that she'd like to talk about that we think also impact. But it's probably different for every person as to why you've developed it. And that's part of the problem in the research field, is it's very individualised and we don't always know.
And I suppose perhaps I could just talk about our research, because we're looking at exactly that question. Why is it that only 10% of women get endometriosis when nearly all of women have retrograde menstruation, we call it, that backflow. And endometrium is a very regenerative tissue. It grows, about a centimetre every month and then is shed in the menses. And we think that there are endometrial stem cells might be different, or more of them are shed into the pelvic cavity, and our whole research has been centred around trying to identify these adult stem cells, which we can now, and then to look in the peritoneal fluid of menstruating women to see if they get shed there, and are they different between women with and without endometriosis. And while the data's not fully there yet, there is some indication that some of those stem cells are present in higher amounts and from women with endometriosis. And not only that, because of the new technologies where we can sequence the genes that are being expressed at one time, all of them, and because we've got these markers to separate the stem cells from the mature cells, we've noticed that that gene profile is different in the mesenchymal stem cells that are shed by women with endometriosis. And in fact, some of the gene expression changes are downregulation of genes that would normally cause the cells to die. And so they have this ability to survive longer in the peritoneal cavity when they're shed there. And we think that this is perhaps a reason why women are getting endometriosis.
So some of the cells that end up after a period in your pelvic cavity, they've literally lost their off switch to die,
right.
so they just keep going there.
That's right.
Now, if I can just pick up, Louise, you were mentioning sites of pain and endometriosis, but Donna, you've got a particular, like the pain goes way beyond the pelvic cavity. Sorry to put you on the spot there, but you did say you were happy to talk about your story. Not too late to backpedal.
No, I'm happy to share my story because it's part of the education process. I do have diaphragmatic endometriosis with adhesions to the pericardium, so it does make me a little bit different than pelvic isolation of pain, and it brings a whole different host of symptoms along.
So it's literally making your heart stick, or the cavity your heart is in, stick to your diaphragm, is that right?
Yeah, well, they're the outside, the pericardium, which is the lining outside the heart, yes, it's stuck adhesions to the diaphragm. I get intercostal, the muscles that run between the ribs, they go into spasms. And so...
Does that make breathing very difficult?
One side is. The other side works fine.
Right.
So you only need a little bit.
Right. Such a chick response. No, nothing going on here, nothing to complain about, certainly no pain.
Gen X.
Yeah.
Yeah, no, it's... I suppose I've learnt to live with it, and I am fortunate than a lot of other women with endometriosis, because it's the anomaly with the disease is that the extent of the disease does not always correlate to the pain or the symptoms of the disease. So I don't have pain equivalent to the extent of my disease. So it does make my quality of life a little bit better. It doesn't mean that I don't get pain, I just don't have... I'm not bedridden with the pain.
Yeah. And for anyone who hasn't already, and I'm sure you are all very familiar with the Endometriosis Australia website and the myths and the descriptions on there, make sure you have a look at that. Also, the Ritchie Centre and the Hudson Institute's fact sheet on endo has got great information completely there for yourself or anyone you know dealing with the condition. A cure. Can we develop a cure for endometriosis? Oh, I see that microphone being handed stealthily away. Reluctantly taken there.
We'd love a cure, there's no question. I'm not quite sure it's around the corner. I think other speakers have already highlighted what the issues are. The main reason being that the cause of endometriosis is probably different in different women. We know that the genetic susceptibility of getting endometriosis is different in different women. So to find one drug that treats the same disease in all women is going to be a challenge. And I think what we probably as clinicians are focusing on now is finding the treatment that's individualized to that patient's problems. And keep in mind that not all women with endometriosis have pain, some have maybe only infertility. And so you need to find out from these women what their goals are. Not all women will want surgery, even if you know there is nodular disease there. I often discuss with them, we've done a good ultrasound, we know you've got disease, but once they know they might need a bowel resection, some of them are really terrified. And sometimes we find other ways of managing their pain. So I think individualized treatment of women that aims to fix their goals is I think currently what we should be trying to achieve.
Yeah, so that's current clinical practice, but looking to our researchers here. So for example, what you're finding with your stem cells, Caroline, even if that does end up being something that might be treatable for a population of women, a subsection of the population, how long would it be before something like that was available?
Well,
you can just say 10 years, that's what everyone always says.
That's right. There's a lot more research that needs to be done, and we would borrow from the stem cell field. There are certain signalling pathways that are quite common in adult stem cell type populations, and in fact we've got a little bit of a research project going now looking at blocking those with specific antibodies, and one of them is showing a little bit of success in an animal model at reducing them. But yes, it's a long, long way beforehand.
So not a thing to focus on for now.
No, it's much in the future, and a lot of research isn't required.
Okay, and do jump in if you've got something to add. Oh, okay, we need money. We need money. Well, and clearly the endometriosis research sector does need money. Do you see a reason that you're not getting the money, Donna?
It's not sexy.
It's not sexy. It's not spoken about.
It's not spoken about. It's not sexy. It's...
Have you got the hard data?
No. We don't have hard data. We don't have enough stuff to give the politicians. So we're in a catch-22 situation. We need money to get the hard data, to get the politicians motivated to give us help. But they want the hard data and we don't have... And so for us to get the money, we need the hard data. So we're in limbo at the moment, but we're pushing forward with it.
And I think you're on the money with the it's not sexy thing, just in terms of the lack of general knowledge for people who are outside of the sector.
And it's a girl thing, or it's a female
It is, and it's a
repro
private
thing.
It's a private thing. But I was wondering why there were those community education ads with all those women talking about being exhausted, and it was all about being anemic. Do you remember those ads about 10 years ago with the different women talking about their different symptoms? This has got to be at least as way more debilitating, and also, you know, to put it in terms that would be understood in Canberra, as big a drain on the economy as anything like that. The figure's $7 billion per year in lost productivity and direct health costs.
Well, I mean, some stats that have come out of the UK are that 3% of UK sick leave goes towards, you know, is covered by menstrual problems essentially.
Wow.
So, you know, that's a major deficit on the economy. And I mean, it's something that needs to be fixed. I think the other problem with the research funding issue is because, unfortunately, this is not life or death. It's chronic, debilitating problem, but it's not life or death. And, you know, sometimes there has to be a life or death issue before it gets a major funding push. And I think, you know, as advocates for endometriosis, as researchers, as people who have endometriosis, we have to sort of speak up and say, it's not life or death, but it's affecting me for my entire life. We really have to speak up and make that heard.
The figures I heard were for a woman with endometriosis, up to almost 60 days unable to work each year. That's effectively, it's almost 20% of your life. It's like being told that you're going to live, you know, almost 20% less time because you're going to be spending that time in bed. But instead of it happening at the end of your life, it's happening all the way through. Plus $12,000 a year, I think. And it's just totally unacceptable. So I'm glad you're all working on it. Diagnosis, we saw that appalling delay in diagnosis. How can we improve the diagnosis? Luke?
Maybe Louise should start, because she's working on interesting...
Great. Louise? Yeah? Don't turn the mics off, they'll fade them down.
Sorry. Yes, so we are doing some research on looking at small RNA molecules in the blood to see if they can give us some ability to do a blood test to check for endometriosis, which would help people who were rural and remote or didn't have access to surgery or didn't have the money to have surgery. There's certainly been several groups around the world that have found some markers, but again, it's quite variable between women, and I think there'll be quite a wee while before we do get those markers. But we actually reviewed all the literature on any diagnostic test, and for there were literally 15,000 papers that people had tried to find a non-invasive diagnostic marker, and we still don't have one blood, endometrial urine tests that we use in clinical practice. So it's very hard to find them, and we are working really hard to do that. We do find that the imaging studies give some people some idea about endometriosis. So there's been some really amazing work in the field of ultrasound with new modifications on how you do ultrasounds. And certainly some of the MRI work looks like it's going to be helpful for people as well. But for small lesions, it can be very hard to tell. But there are really interesting ways that people are looking at that, and they're looking at different markers in the blood. They're looking at putting combinations of different proteins and RNAs, and there's very large groups looking to do that now. And I think that there will be a non-diagnostic marker, and it may be a combination of imaging and blood and other markers that will help us.
So these are molecules that are telltale of having endometriosis, of having a lesion somewhere in your body that end up circulating in your blood. So a simple blood test, and you get the blue line, or the what? Probably not the blue line, actually. You'll get some indication that you have those markers.
Yes,
and
and it may not be completely diagnostic, but it might be much better at giving you the idea that that's probably what's going on. And then you may still need to do surgery to define it, but at least you'll have a much better idea how likely it is.
And Gemma, you're actually working on this.
Yeah, I'm working in a similar area, I guess, minimally invasive diagnostics. But
Gemma, that is such a great accent. I didn't understand a word that you said. Can you just slow it down a bit for the Queenslanders in the room?
minimally invasive diagnostics.
Minimally invasive diagnostics, so not a laparoscopy.
No. My research really has the yuck factor. I work on menstrual fluid. So I guess my thoughts were that at the moment, blood tests, urine tests, even things like saliva tests haven't given us anything concrete to be able to diagnose endometriosis properly. So a lot of the problems with endometriosis, start with your period. That's how we think endometriosis is initiated. So I'm actually investigating factors which are present in menstrual fluid, which we hope will differentiate between a woman who does or does not have endometriosis. So we can actually collect menstrual fluid using a menstrual cup, which looks like a little rubber egg cup. The woman can collect the menstrual fluid herself, so that's why it's minimally invasive. It doesn't require any intervention by a doctor. And she can pass that menstrual fluid on to a diagnostic pathologist, and they can examine that menstrual fluid for various factors which might be present, which can then hopefully diagnose endometriosis. We can also actually collect pieces of tissue from the menstrual fluid, which contain cells, and Caroline has talked about the stem cells which are present in menstrual fluid, but there are other different types of cells present in the menstrual fluid as well. And we can actually check the behavior of those cells to see if they stick or adhere, and if they invade in laboratory assays. And once we can see if the function of those cells has changed, the behavior of those cells has changed, we can actually then look at the gene expression in those cells to try and give us, again, an indication of differences between women who have and do not have endometriosis.
So a cell that's behaving differently presumably has either genes or proteins on its surface
that are altered,
that are different, so that would become the marker that you'd be able to identify.
So we can take a few different approaches to try and develop this minimally invasive test.
And again,
hopefully.
Let's just say 10 years minimum on that.
Can I just add something too? When we're talking about addressing the diagnostic delay, I think we need to talk beyond just having effective tests. We also need to talk about the people who order the tests and how do they know when to order them. And when we look at the diagnostic delay, the research is showing that the largest chunk of that delay does come from when women seek care to when they're diagnosed. So the smaller part of that delay is from symptom onset, so when women notice that something's not quite right, to when they go to see their doctor, there's a bit of a delay there. And then once they see their doctor, and to the time when they're diagnosed, there's a longer delay there. So we need to kind of think about what's happening in healthcare practice as well that's contributing to that delay.
Which leads beautifully into our next question. Thanks. I'm the professional here, but by God, Kate, you're pretty good at this stuff. How can we most effectively educate healthcare professionals, and we're not just talking about GPs here, healthcare professionals worldwide to reduce time to diagnosis and improve treatment and care of women with endometriosis?
So this is one of my research interests. I'm Kate, by the way. I'm a research psychologist with the Gene House Research
Did I not
Unit.
do that at the start?
No, sorry.
What a shocker, sorry.
So I look at women's experience with endometriosis from the perspectives of both women and clinicians. And the research that I've conducted so far with clinicians suggests that in the absence of effective treatment options and research evidence, a lot of clinicians are drawing on social, historical stereotypes around women and their bodies. So the idea that it's a girl's problem, or to be a woman is to be in pain, or if you have a baby, it will get better, things like that. I think one way of addressing this is looking at the medical curriculum. So ensuring that clinicians have that training to be aware of the social elements in their healthcare practice. An example of that is the Harvard Medical School. They've just started a few years ago a social medicine unit that's compulsory for all doctors, and it leads on to all areas of their curriculum, and it's about acknowledging these what they call social pathologies in medical practice. And I think that's something that's really important, particularly when you have a condition that is affecting women. I think it's really important to acknowledge that social historical context when providing healthcare for that condition.
And Donna, I'm pretty sure you're going to have
Gender-wise,
something
yeah.
to add to this. Donna?
Yes, we are working at Endometriosis Australia to increase the education with GPs. We're looking at how we can set a standard of care that they will follow. It's encouraging that I've talked to first and second year med students at UNSW, and they all knew what endometriosis was, and the actual factual definition of the disease as well. So that was quite encouraging. Had young guys had no concept of the quality of life issues associated. So in my ever so blunt way, we had a chat about, could you imagine not being able to urinate, defecate or have sex? And it was shocking for them. So if you put it into those basic concepts of quality of life, it hits home. We are definitely, it is on our radar, and it's something that we're working, has been brought up with the government as well, of how we can attack this problem. And with the government, it's also, how is it not going to cost them a lot of money? So
How it's actually going to save them.
how it's going to save them money, and how we can implement it in the least disruptive way, so we can get it in there without it causing too much angst.
And Angela, what would have made a difference? Oh, she's being showered with microphones. Hear it in stereo. What would you like to see change in this whole process with the healthcare professionals around maybe a more holistic approach?
I definitely think we need a holistic approach to it. Andrew was talking in the sessions earlier today, about centres where if you go to a specialist after having, even if you get a gold standard of care in surgery, after surgery you might still have pain, and you're your own advocate at that point, and you have to try and get it written and navigate all these different options that you have.
While in pain.
And
suffering anxiety.
Not knowing if it's working, not knowing if it's in your head because you spent your teens and early 20s being told that it was. So I think specialists need to stop operating in silos and need to talk to each other when you have a group of specialists, so that they're coordinating your care rather than, like for me, I shouldn't be coordinating my care because I'm not a specialist. I don't know. So there's that, but then there's also, I think, at the very beginning, it's the GPs need to get you off to that scan as soon as possible, and also you should know what to be asking for and what to be saying when you go to your GP, and have that maybe from schooling, being able to go into a general practitioner with the strength to say no. What is happening in my body isn't right. and it's different from my friends, and I know this because we've had a conversation, and it's not just everybody that has a period has pain. It's, no, if you've got, you know, if you're in severe pain, that's not normal. So let's do something about that.
Thanks so much. And Andrew, this model, or this, the model that Angela was saying, you were mentioning, is that something that's actually being practiced, or is that an ideal? Is there anywhere in the world that sort of has a best practice approach for a more holistic care for women or people with endo?
I mean, I think many countries are working towards that model. We have a model in the UK, which is that we have accredited centres for endometriosis, and we've got we're driving for, if we like, a managed clinical network for care, so that would incorporate the GP as well. At the moment, the centres, in terms of the accreditation, is very much based around the surgery for endometriosis and auditing the outcomes for surgery, which is good. But I think, as Angela alludes to, a centre is it's much more than that. It's multidisciplinary, so it's very important that a centre includes a pain specialist, a specialist nurse, pain psychologist, and also access to colorectal surgery, urologists as well, and physio as well. Physio is much more difficult to bring into the fold, and we've certainly found that in the UK, but very important.
Yeah, any culture change always comes with difficulties. What's the situation in Australia along that line? Do we know if there's any models like that?
I think we're not quite as well organised as they are in the UK or in mainland Europe. I think there are a lot of expert surgeons that have surrounded them with the right specialists. So we're blessed in Melbourne, certainly, with excellent physiotherapists, something that clearly Andrew's admitted is more difficult for them to get in the UK. So, but it is not formalised. So I think for patients the difficulty is knowing where to find these specialists or these networks, and it would be probably really advantageous for patients and GPs, referrers, to know, all right, well, that's an accredited centre, and if I send my patients there, they're going to be looked after well.
So an accreditation is a good thing, because we can't otherwise promote particular specialists. There's no advertising, and I know, Donna, you've run into that problem, having to have silent Facebook groups and things to get that across. That's okay. I just I think the accreditation model is it sounds like a good idea. We'll just keep moving because we need to get to your questions. So we have, the next one is, can we develop a non-invasive screening tool, which I think we've already spoken to a bit, unless anyone wanted to add anything to that, very briefly. The fifth one, how can we most effectively maximise and/or maintain fertility in women with confirmed or suspected endometriosis? So we haven't really spoken about fertility before, but Angela, you've had a child. Sorry, not Angela. I'm sorry, Donna. You've had a child, and and Angela, you will. You know, when you're on stage, anything's possible. Louise, would you like to speak to this, how we can maximise?
I think one of the things is to be aware about fertility, and I also think that we need to start thinking a little bit more about prevention of fertility problems later in life. And I do think I think we need to do a whole lot more research to see if things like actually suppressing periods for a long period of time, either with the pill or with the Mirena, actually has a fertility benefit. And we've done a lot of research on pain, but we really are very poor on research on the fertility.
So we don't know that about the fertility implications?
No, we don't. And whether just not having as many periods means that you've got your eggs haven't been exposed to inflammation the same way, and that your fertility may be better, we don't know if that's effective. And I think we really need to get the data to find that out. And we are trying to look at cohorts and following people up through life to see if those interventions that we start earlier in people's lives have an impact on ovarian reserve. I think there are some tests we can do. We can actually measure egg numbers, and we know that women with endometriosis have slightly lower numbers. We do know that the inflammatory process has an effect in the peritoneal fluid, has an effect on egg quality. But there are also things we can do now that we're just starting to develop, like we can freeze eggs for people. if their numbers are getting low. And these are things we don't know quite how to use these tools. These are very new things. We've had egg freezing probably for about 7 years, where it gives you a chance of pregnancy, but not a guarantee. And we still don't know exactly where that fits in for people, but there are things we can do now that hopefully will help people preserve their fertility in a situation, particularly if they're having surgery or losing an ovary. We may be able to help. So I do think there are some things.
Okay, time's getting away from us a bit, so we might just try and get just one comment, I guess, on each of the last four, except for this one. How can we most effectively manage the emotional and or psychological impact of living with endometriosis? Kate, Angela, Donna, take it away.
So I just published a paper on clinicians' perceptions of psychosocial care for endometriosis. I interviewed GPs and gynecologists, and
So that means what doctors think about the kind of mental health care that their patients are getting around it?
Psychosocial doesn't necessarily just mean mental health. So it means the psychological and the social aspects of living with endometriosis. So that's, again, taking more of a holistic perspective that the disease happens to be experienced by a person, not by a body.
Right.
So they, I did in-depth interviews with them, and they all said that they didn't feel like they were equipped to provide psychosocial care. The GPs thought they were best placed to do it. And about half the gynecologists I talked to didn't feel like it was a part of their the type of care that they offer. So I think that is something that we need to address as well, the lack of medical training for providing psychosocial care and addressing the emotional impact on women. Another thing that I think is really important is just general education and awareness for the public. And a great way I think of doing that is secondary education. So an example would be Endometriosis New Zealand has this great program called the Me program, where they've done menstrual education with boys and girls. And I think that's another important aspect. It's not just a girls or a women's problem, it's a society problem. And they're currently trialling that, as far as I know, in Adelaide, yeah. And I think that's really great. And maybe in the future, it wouldn't be a separate program. Maybe menstrual education would be part of sex health curriculum, and we'd have that better awareness and be able to provide better support to women.
So we have brought that up in Parliament. So we have brought that up as an issue and a topic. It then becomes too hard basket because we then got to go to the states, because the states are what deals with the education. It doesn't mean we're giving up, it's just mean we've got to come at it from a different angle, big on problem solving. So the education is really key, and getting boys and girls involved is really key. Managing, I think our role with Endometriosis Australia is also about empowering women with the knowledge. So empowering you with the knowledge and hopefully with some tools to be able to put together your team and create your village, so that you've got your teams of, whether it be your naturopath, whether it's be your surgeon, your GP, your acupuncturist, but you surround yourself with multiple modalities, and that's your village, that's your team. And then you've got your support network as well of your family, friends, and you're not always going to convert your family. We've all been there and done that. But get that we have to be, as women, empowered enough to create that change. We can't expect someone else to be doing it for us because we've sat back and it hasn't happened. So we need to take the bull by the horns and create our own village, because it is a community issue, and so let's have a community solution to it.
Yep, with bullhorns involved.
Yep.
And you driving that. I like that a lot. I think that's going to happen. Did you want to add something, Angela, or you're okay? No, good. Okay. Now, the eighth issue, or the eighth research question, what are the outcomes and or success rates of treatments aimed to treat endometriosis as opposed to managing it? So, Andrew, could you just briefly go through those treatments and then talk about their relative success rates, I guess?
So I suppose a bit of background to the question as to how it came about. So as we've said, there isn't currently a cure for endometriosis, and I think what came across in the survey was that patients with endometriosis were frustrated that they had to manage their disease. So perhaps with lots of the things that we've talked about, and they were keen that we invest time in looking at something that would actually treat it. So maybe not completely cure it, but that's the sort of subtle difference here. I think at the moment, probably what we have available are drugs, approaches that manage the disease. There aren't many people, I would say, have found their own treatment. Fortunately, some women respond very well to surgery. Some women do respond well to some of the hormone treatments that we have available, or even some of the what we call neuromodulator, the drugs that act on the nerves in the pelvis. But I think that's where this question's come from.
Right. So, yeah, it's just horses for courses, for want of a better bullhorn analogy. The ninth research question, how can we most effectively stop endometriosis progression and or prevent its spreading to other organs? Luke?
Well, usually as a surgeon, if you go down the surgery route, we obviously try to remove most of the visible disease. That's not always possible. Sometimes the lesions are quite small and you might not be able to remove everything. And so what's important then is to add follow-up therapy. And as been alluded to before, if you stop cycles, if you can stop a woman having menstruations, you're going to reduce the risk that she will reseed the disease. And certainly if you've left lesions behind, they can also be the source of reseeding. So for instance, an oral contraceptive pill or a progestogen treatment is relatively cheap and is a well-proven medication to reduce the recurrence risk.
Right. And Angela, I know that you've got some fairly strong views on the surgery side of things, and I think you should just make them now, the two possible surgical options.
I think Donna might have stronger opinions on this than I do, but excision versus ablation.
Yeah.
Excision being the gold standard, but not heavily, it's not widely practiced. Often don't know who practices it before you go in. I didn't hear about it, and fortunately I did see an excision specialist, but I didn't know it when I had seen him. I asked the question afterwards after finding Endometriosis Australia, which happened after my surgery. So an ablation has from what I understand, a stronger chance of recurrence. And then these people who have had surgery then end up going and seeing an excision specialist, and they have to treat what is a really poor job of surgery. And I just think that the fact that anyone having this surgery has to then go and have another surgery to fix a mess that someone's made is really that's
So
really
very strongly
poor.
on finding a good excision surgeon, which can be
And we should
difficult,
know who they are.
and going excision, not ablation. So, comments? No?
I would just try and modify that statement a little bit. I think there is evidence, and the evidence suggests where the disease is relatively mild, that there's probably not an awful lot of difference. That's what the evidence says between ablation and excision. Once you start talking deeper lesions, I think it's a bit like the tip of the iceberg phenomenon. You're going to just laser off the tip of the iceberg, and you leave really the root cause of the disease behind. And I'd make an argument to always do excisional surgery after you've done an ultrasound. I think, or other imaging modalities like MRI. You only want to do the surgery once, especially in the patients with the more severe disease, because it's the repeat surgery that has a much lower return on your investment. So once you go in and you know you have disease, you want to make sure that your surgeon is well prepared, that he knows what he's going to find before he even starts a surgery. And if I can make one strong call, is that patients should demand to have an imaging technique performed before they do the surgery. Either a good ultrasound or an MRI, so that the surgeon knows whether he will need a multidisciplinary team on the day. If there is disease on the bowel, he should have his whole team ready.
Donna, is that on your website? Because if not, you should pop that on right now.
there's a lot of political stuff, so we do what we can. But, you know, we do advocate that your first surgery should be your best surgery. So we know that repeat surgery doesn't have good outcomes.
Okay,
So-
Luke, I think you need a website where you tell people to do that then. Yeah. Okay, a last one before we get to, and I'm sorry this has taken longer, but I'm sure you'll agree there's been a lot of really valuable information here. So what are the most effective non-surgical ways of managing endometriosis-related pain and or symptoms? And we can look at current clinical care and in particular the needs of sufferers. So I've got Angela or Donna or Luke or Kate. Donna, go
I'll
for
just
it.
quickly go. I think we can, as patients, we can do things like helping reduce our inflammatory load with looking at our diet, looking at managing our pain and those kind of things. So if we can do that via whether it's pelvic pain physiotherapy, relaxing those muscles down, all those type of things that can, as I said, create your village. Get your expertise, surround yourself with the good people.
Luke?
I would agree with that. I think it has to be a mix. And again, the first thing should be to listen to your patient to understand what the problems are. I find a lot of my patients have enormous help with good pelvic floor physiotherapy. A lot of the pain issues that they have are because of long-standing reluctance to even have sexual intercourse. They completely tense up, and it's just really, it's a secondary problem. The disease is no longer almost the endometriosis, it's pelvic floor dysfunction. That's secondary to the original endometriosis disease. So really listening to patients, understanding which different pain components exist, and then treat those individually.
Thank you. And Kate?
From a research perspective, I think it's important that we understand how women self-manage the condition. So what have they come up with in line with what Donna was saying, which is something that my colleague Becca Hara, sitting down there, is looking at. And I think that would be really helpful to learn from women what they're currently doing and getting that into the medical literature.
Fantastic. Now, it's over to you. So we have got some microphones, which I think are all here. Do we have any, are these two the volunteers who are going to run the microphones? Come on, out you pop. Does anyone have a question for our panel? You've got about 35 minutes now. It would be absolutely great to get on a roll. We've got a woman in the back row up there. Who's the microphone? Yeah. Thank you. We'll need one up here, yep. Yep. And if you could just let me know where the next question is. So there's another one over there, thanks. And if you've got an idea from this who might be best to answer your question, that would be great.
Is there anywhere in the world where endometriosis doesn't exist, or it's at a really low rate, so we could kind of get an idea of the environmental cause?
Great. Is there a natural negative control?
I can't say, I don't think there is for women and for humans. I do think there is some work in primates, because baboons also get endometriosis. And the only time they get endometriosis is when they're put in captivity and they're not able to be in a community, because and then the female baboons don't get pregnant as much and they have much more menstruations. And that's one of the reasons they think that the retrograde menstruation might be a cause. So in those populations, being continuously pregnant seems to help, but it's probably more about not having periods over and over and they're not getting the ability to actually get the endometriosis. I don't believe there's anywhere in the world. I think it's 10% across most countries, but Andrew might have a bit more information on that.
No, he doesn't. Up here.
Hi, I actually am an identical twin, and I've been suffering with endo for years now, but my twin sister does not. Are there any sort of twin studies going on at the moment, or anything that
you should see the radars coming up on the researchers there for the twin study. Caroline. Enlist.
There are some genetic studies and twin studies, and I think when there's identical twins like yourself, I think that the concordance or the endometriosis is more common if they're the twins are identical, whereas if you're not identical, then the incidence is no different.
So you mean if
Okay?
you've got in identical twins, the rate might be 50% or 40% or something, but not necessarily, well, certainly
for the
not
other
both.
twin, yes, there's more chance of getting endometriosis for the other twin. Your sister is incredibly lucky that she's not in that category, but that's usually the case. Whereas if you're a twin and you are not identical, the chance of getting endometriosis is the same as the normal population.
And Luke,
Okay.
you've got something there?
I don't think it's entirely correct. I think the general rule is if you have a first-degree sibling, let's say a sister or a mother with a disease, your risk is about 5 times higher, 5 to 7 times higher. So it doesn't need to be an identical twin, but they have done identical twin studies, and from that they've learned that about 50% of the reason you have endometriosis is genetic. And then for different people, which gene it is different. So it's not like cystic fibrosis where it's only one gene. So there's lots of different genes involved, which makes the whole field really, really very complex. It was nice if it was one gene, we could just target that one gene and find a treatment. So there is a fairly strong genetic component to it.
Just nothing very clear cut. Questions? Hands up.
I got one.
Oh, you were there. Thank you.
This is just in regards to, I guess, the government, Australian government, and we can talk Victorian government as well. Earlier this year, the state strategy for women's sexual and reproductive health was released, and endometriosis and polycystic ovary syndrome was identified as a key priority. Yeah, in Victoria, yeah, that strategy was released earlier this year. What is the current climate right now with the Australian government or even the Victorian government support around endometriosis? And as you know, Endometriosis Australia is, you know, an advocates for this disease. What are your challenges and maybe some of the successes that you've seen thus far in getting them on board?
Well, we've had huge wins because we've actually made it to the floor of the Parliament. So that's, you know, an absolute amazing win this year. It's not, I think in the women's health policy, Jane, correct me if I'm wrong, but it was only one paragraph in the whole of the federal women's health policy documents. It's only mentioned in one paragraph, and that's within fetal medicine. So it's not even on the federal government radar. So we have 2 fantastic ambassadors in Gai Brotman, and we've now just put on the government chief whip. So we have a bipartisan approach, and so Nola Marino, she's come on board as well. So she's very passionate. Her daughter has endometriosis. And is very, very passionate about creating change. So it is a watch this space. Gai has and Nicole have started up the Friends of Endometriosis Parliamentary Awareness Committee, big mouthful, but that's our first step. So we then have to get 10 ministers to be involved to launch that, which we're hoping at the end of the year we do that. So it's, compared to a lot of other areas, we've made big inroads in 4 years. We've still got a bloody long way to go, and I did swear. Sorry.
Flippin' heck, you did, but I let that one get past.
But we've got a long way to go, but we are making huge headway, and all the groups are working together to get that across the line. So unfortunately, it may be for the future generations, but I kind of like to think of us as the suffragettes for the next lot of women. So we're making way for the next lot of women with endometriosis.
And just double underline the suffer bit at the start.
Yeah, exactly.
You're really paving the way in blood. There was someone with a question up the back there. Sorry.
Hi, what is the risk of developing cancer from endometriosis, and what should we be doing to be monitoring it if there's like a higher risk?
So we're talking a bit about this morning, so I assume you're referring to ovarian cancer, which is being discussed a lot. Sorry, I can't see where you are, but sorry.
did you put your hand up? Yeah.
Yep.
So it's not just people who have been at the symposium today. It's
Yep.
everyone.
So your risk without endometriosis of developing ovarian cancer is 1.3%, and it's increased about 1.5 times if you have endometriosis to about 1.8%. So there is definitely an increased risk, but I think what's really important is to put that in perspective, because a lot of people, I think, are either seeking treatment or receiving treatment and screening, which perhaps isn't necessary for this increased risk. So if you, say, for example, carried the breast cancer gene, which puts you at risk of ovarian cancer, one of the genes called BRCA1 would increase your risk to 39%, and there's another gene, BRCA2, which would increase it to up to about 17%. So in those cases, women are advised and often undergo what we call a prophylactic or a preventative salpingo-oophorectomy, removal of the tubes and the ovaries. So that's to try and put it in perspective in terms of that risk. And then there's risks of other types of cancers as well, which are also much, much higher. So what I would say to women with endometriosis is be aware of the increased risk. But at the moment, I wouldn't seek any sort of surgery like this, because these surgeries, although are effective at preventing ovarian cancer, also carry risks. The surgery itself carries risks. And the fact that you have your ovaries potentially removed prematurely can also increase your risk significantly of things like cardiovascular disease. The other area that people are seeking help for and clinicians are sometimes offering advice about is increased screening for ovarian cancer, and unfortunately there isn't a good test for screening for ovarian cancer at the moment. So what we're trying to do is try and reduce make women aware of, with endometriosis, of the increased risk, but reduce the anxiety and just say to them that at the moment they don't need to do anything more than if they were without endometriosis.
Thank you. Next question. Yes?
Sorry. Before tonight, I actually hadn't met anyone who had endometriosis. I'm the only person in my entire family that suffers from it, so I'm fairly unlucky, I suppose. But trying to get everyone else in my family to sort of understand what I'm going through has been really hard. And even like talking about it has been pretty difficult because they just don't understand, or there's just sort of like a barrier, I suppose, especially with like my dad and stuff as well, so it's a bit different. So I was just sort of wondering what sort of local and community awareness is being made to get that knowledge happening at a sort of like a smaller level.
In Victoria, you're quite fortunate. You do have the Epworth. Is it?
It's sorry. What's the name of it? At Epworth Freemasons, Wendy Dawson. I'm not sure if she's in the room tonight, but
Just hold the microphone a bit closer.
Runs a support group
At Epworth Freemasons.
Yep, bi-monthly. And
is that twice a month or every second month?
That's every second
Thanks.
month, I think. Oh, God. But that's welcome for partners and or family members to come along. And I think it's a great environment for people and partners and family to learn and to see the other people who are going through endo and realise that the stories are common. So there's that, and then also Donna's site.
Yeah, so we also do free medical webinars. So there is lots of videos, and I'm trying to get more out there for you to be able to share with your families so that they can have an understanding of what the disease is. We also have our closed Endometriosis Australia discussion group, which is more on an education prospect, but you can also invite your family to come along to that. I would encourage you to take family member, at least one, with you to an appointment so they can hear it from the third person about the disease, because we have that gender bias of that historical thing of we're hysterical women and hysterical uteruses, and you know, we're just all hypochondriacs. So to get over that, if you bring someone within your family or your partner along to an appointment, then someone else is telling them about the disease. It's not you trying to get your message across. But joining in with the group, and we have a list of all the support groups, but they're all online. There is a couple that are face-to-face, but it's a little bit disjointed, but we do have a list on our website.
And I have to say those videos, those short videos, the medical webinars are fantastic. They're really, really spot on. So if you do want to share them, they're great.
Oh, can I just say, I think there's quite a lot of very good online information as well. I think Endometriosis Australia has a really good blog with a lot of information. Pelvic Pain Foundation has a lot of information. There's quite a few websites where you will get really quite accurate information and ability to find things that suit your personal symptoms as well, and I think they're really good.
So we've got another few questions. We've only got about just over 15 minutes, so it's about another 4 questions. So thank you.
Okay, so I used to live in North Queensland, Townsville, and once I got diagnosed with endo, I had never heard of it before at all, and the only way I found out about it was Google, of course, lovely Google, but I'd never heard of it before, been in a rural town or anything, and once I got told that I had endo by surgery, found out a few of my friends had it, and everything else, and they're like, oh, that's what we have. And I'm like, well, why can't we talk about it? It should be talked about it. So my question is basically how are you going to be trying to reach the rural communities in the country?
I travel a lot. I grew up in Cairns, so I get you from the rural perspective. I just tried to give away 10 free tickets to every high school in Cairns to come and see Endo What, and I got the response from the female teachers at the schools were, what is its rating? Is it rated R? And I'm like, yeah, that's me. I'm peddling porn to teenagers. So I couldn't even give away free tickets in Cairns. That was how bad it was. So they're not open to it yet. But Townsville was great. I showed it up there, and we've been to Albury Wodonga. We will keep doing it. We're trying to do more online stuff so that, one, because we're such a small organisation, and I volunteer full-time, and I am it. So we've got great volunteers that help us on the ground, but I'm the only full-time volunteer at the organisation. So we are trying to get ways that we can do online toolkits and webinars and events so that we can get to the rural areas, and when we have the opportunity to go, we will. But my family needs to see me every now and then.
Just before we get to you, Luke, just with the Queensland slag off before, that's because I'm a Queenslander, okay? Yeah, no, got it, yeah.
But so what I'm hearing is a call for more volunteers, really. I mean, as surgeons and physiotherapists, we can do what we can to help you. We can set up networks of excellence, centres of excellence, but you need to grow that support network, that support group, and it takes volunteers. Yeah, excellent.
Yeah. Fantastic, thank you for that. And there are microphones everywhere. Who's got the mic? Yeah,
I've got one.
Good girl.
Just in relation to, I heard one of the questions was saying she didn't know anyone who had endo. And it's kind of interesting because we hear this 1 in 10 women have endo, but when you get diagnosed, often you do feel like you're the only person you know with endo. And I know when I got diagnosed, I didn't know anyone who had it. And I also go to the Epworth Freemasons support group, and a few of us here do, and it's actually nice to come to stuff and know people. And while I guess all the online stuff is great to have available when you're first diagnosed, can be also very overwhelming to read all this stuff on your own and think, holy God, how am I going to cope with this? And I just wondered what kind of options are there. Obviously we have every 2 months we meet up, but that's only a small portion of women. And I wonder, are you guys working on, or do you know of anything that might allow people to meet up more freely, or go for walks, which a couple of us have done before, or little things like that to try and meet people who, might have some insight, I guess, beyond just the one group, I guess.
So every town I go to, or people that come to me, so now we have the Cairns Endometriosis Support Group, we have the Townsville Endometriosis Support Group. So whilst they are online, every one of them places, I encourage them to start up their own network, because it's the only way it's going to happen is with you guys. We can't organise it, and we can organise events, but endo girls don't always turn up, and it's not their fault. It's, you don't know whether you're going to have a good day or a bad day. And so that tends to be half the problem, is that they start getting off the ground and then they peter off. So the online seems to be a reliable way, so it doesn't matter how sick you're feeling or how crappy you're feeling, you can still get online and be in communication with somebody. There are a few places like Leeton, which is my husband's hometown, which is out near Griffith, and they have a coffee meetup. So whenever I go home to the farm, I always organise to have a coffee meetup with them because I'm going to be in town. So it's no different to, and I just email them or I Facebook them. So it's the same thing. You just need to organise within your little group, start up your little subgroup. So if it's your suburb, start up your little suburb as its own Facebook page, but connect with the big ones, but have your little network that you can just meet down in the corner and have a coffee or go for a walk. But it's harder to, a lot of the hospitals had started them over the years, but they've also fallen over. I think Epworth's Freemasons is the only one that's, and that's around the country, that's really quite strong.
Yeah, it is a bit like we need an app.
They're saying we need Tinder for endo.
Tinder for endo. But it is a field that I'm certainly interested in, sort of coming out the other side, that I think we need to expand our community, and that does take our commitment as the people suffering from endo. We need a team of people that we can call upon, and maybe if that's 10 people, 20 people, and only a few are okay that day, then that's okay. But I think we all need to make that commitment within ourselves, that we need to support each other rather than completely rely on the specialists, because that's not the support that they can give us. We need to give each other that support. And that's within our, across the trans community and the intersex community as well. I think that's really important that we open that field up to everyone.
Thank you, Angela. Who's got the microphone? Thank you.
My question is, I had a bicornuate uterus when I was born, and I was just wondering, well, if people don't know, that's 2 uteruses instead of 1. I want to know, is it more common with women who have those 2 uteruses, or like a unicornuate uterus or something like that, to have endo more severely, or... Because I do have stage 3 endo.
It's more common to get endometriosis if you have an obstruction of the uterine tract at some level, so that more fluid can go up into the pelvis. If you have 2 uteruses, you do tend to have much heavier periods, and so it may be that more blood can flow up into the cavity as well. So I don't think there's a lot of data to say that with 2 uteruses you would be more at risk of endometriosis the way we know about obstructions, but it wouldn't surprise me just because periods tend to be much heavier.
Okay, I reckon we've got time for another 3 or 4 now, because we're getting through them a bit faster. So please just make sure you've got your hand up so we get a decent... So this young woman down here as well, after up there. Yep.
Like Donna, I have diaphragmatic endo. What do we know about the disease travelling upwards, and our treatment methods as well?
Diaphragmatic endo. What do we know about the disease travelling upwards, and treatment methods as well?
It's a very good question, because you would think if it was retrograde menstruation, the blood would pool always down in the pelvis, and that's probably true. But we do know, number one, that pelvic fluid does circulate. We also know from ovarian cancer, for instance, that ovarian cancer cells that are shed by the ovaries will circulate through the tummy. So that's one possible way, that they do eventually make it up higher in the abdomen. But we do believe that in some women, the cells can also travel through the lymph vessels or the blood vessels. And so there's certainly other ways that you can develop endometriosis. For instance, it's known, I think Donna was saying, she has it in her pericardium, the little pocket around the heart. That most likely is because of a different mechanism altogether rather than retrograde menstruation.
Who has it now? Thank you.
When I first found out that I had endo and went through the surgeries and the pill and everything, then I was just doing other research to see what else you could do in addition to like non or invasive things that were non-invasive. And a lot of websites and things that I read were discussing about diet and following an anti-inflammatory diet. And I just wanted to know where the research is with that and how much research is done with that, or are you just sort of following something like that in good faith that it makes sense that if you have inflammation in your body, you just try and reduce it?
Like endometriosis gets stuff all
Funding.
money for research, funding money. Complementary medicines do as well.
Yeah.
FODMAPs have out of Monash, they've got some good research about having a low fructose diet, so that works on that side of things, and that reduces the inflammatory load, so it stops the bloating and that kind of thing. And so there's a lot of microbiome research going on as well in other areas, which I think we need to look at also outside just endometriosis, but there's there's a lot of inflammatory diseases. So have a look through other disease processes that their research in diet and anti-inflammatory will possibly play a role that we could look at to work with for endometriosis as well. But FODMAPs has probably got the best research, clinical research to go with it. It's like a lot of stuff out there that's anecdotal, and we need to get the hard data to back it up to say what works. And then it's going to come down to the individual. Works for some, doesn't work for others. We've got some good research going on in acupuncture at the moment, which is fantastic for endometriosis. So it's specific to endometriosis. So it'll be good to see, they've got some prelim data coming out, and it'll be good to see the full piece coming out later on.
Great. Next person with the microphone.
Hello.
Off the back.
My sister and I, we both have endometriosis, and we both are unable to take estrogen due to factor V Leiden, and I'm sure that there's multiple people who can't take estrogen. We were just wondering, in regards to, is there research around using progesterone-only medication? We've had probably, 7 laparoscopies between us, and we've tried multiple different therapies. But yeah, we were just wondering if there has been actual research into progesterone only.
Probably the best known treatment for endometriosis, which is medical, is the combined pill, which has estrogen and a progesterone in it. But there are other, basically that treatment is being given to try and stop your ovaries working, and you can do that with a progesterone on its own, so you can take that as a tablet. You can be given that as an injection, a depot injection. It can also be given as an implant, or even be given through the Mirena system. And when they've done, researchers have done studies comparing these head to head, there really isn't a huge difference in terms of the benefit you get in terms of managing pain. It's just a question of which one suits you best in terms of side effects. And of course some don't work for some people as well. So I think there are lots of options that are progesterone only.
Thank you. Down the front here.
Hi, I'm just wondering, endo belly, like that's what I call it. I'm sure that's what a whole bunch of us call it. I know food is a trigger. I know that certain things are triggers, but sometimes you literally will just, I say, blow up, and you'll look 6 months pregnant and you haven't had anything to eat. There's not a certain trigger. Do you have research on that? Like, why are we just looking 6 months pregnant? How do we stop it?
FODMAPs have done some really good research on that.
So FODMAPs, how do you spell it?
Is FODMAPS.
Yeah.
And it's they've done MRIs, and they look at the amount of gas that goes into the gut, and it's to do with fermentation. So you've got to look at, it may be not what you've currently been eaten, but it's how the microbiome's reacting with what you do eat. So the endobelly is a lot to do with that, and the body's inflamed as it is. So you're kind of behind the 8 ball. But FODMAPs would be the one I would say, and they had some really good data because they presented that a few weeks ago. So they had really good data, and they showed the images of the difference with these MRIs. So it was really nice, tangible and visual learners like me could understand it. So it was really good.
Thank you.
You'll always get a seat on the bus if that's tiny little silver lining. Sorry. We've got time for another couple. Hands up.
I had 3 laparoscopies and a lot of unsuccessful IVFs, which unfortunately tonight we didn't touch on. But my question now is, I'm one of the unfortunate that I can't actually take some of the therapy you suggest, pharmacological therapies you suggested before, because I had very bad reaction with the pill, with Mirena, with a lot of all the hormonal therapy. So, and I know that, as it was mentioned tonight, that the hysterectomy is not a cure for endometriosis, but now I am at the point where my specialist is suggesting to have an hysterectomy, and I agreed, and I'm actually on a I'm thinking about having it until I start reading it, and now I'm absolutely confused about, is this the right thing to do or not? Are there any tools, any support for people like me who are trying to make such a big decision, and it's a decision that you can't actually, walk back up, change your mind after you've done that? So what is the best thing to do when you find yourself in this situation?
It's a tricky situation. I can't obviously comment without having more detail on your personal medical history. But as a general rule, when you're uncertain about advice that's being given, I think the best thing you can do is, before committing to that advice, is to go and seek a second opinion. And unfortunately, the more opinions you will seek, the more different pieces of advice you will get. But you will learn, and eventually you will usually get advice, or you might piece together advice from the different opinions you've been getting that you think is the right approach for you. And so that's the best advice I can give you.
Is there any hard and fast, is there a time when a hysterectomy is the answer?
It depends again on a whole range of circumstances, whether you're still thinking of starting a family or your family is not complete yet. But I think if your family is complete, or you're not wishing to have another baby, a hysterectomy, especially if you have adenomyosis, keep in mind a lot of women with endo have lots of other comorbidities, and adenomyosis is probably one of the more common ones. Adenomyosis is very difficult to treat medically, and you've already told us that medication is not something that you seem to tolerate very well. So a hysterectomy, if it's done with keyhole surgery, can be a very good option for many women. So it's certainly not something that you need to necessarily be terribly afraid of.
That does not count as a second opinion, though, because it was gathered here at a public forum. So, sorry, that couldn't be more help. Next questions. We've still got time. There's 4 minutes. Yeah, sure. You waited long enough. You get a bonus question.
So I read something on the internet, and I know the internet can be full of
This is already
myths.
my favourite question of the night.
And obviously we're all holding on to that hope of some form of treatment or cure. But I read an article about chemotherapy being able to help us in a way, that they were doing trials or something, that it can help with the tissue, kind of like with cancer. Would that, like, it kind of reacts the same? Is that real?
I'm not sure what you've read or where you've read it, but it may be referring to some work that I talked about today that we've been doing in Edinburgh. So we've been looking at how the cells on the wall of the pelvis in women with endometriosis behave a little bit like cancer cells. So what we've been doing is looking at whether some cancer treatments might alter the way that these cells behave. So it's very much early stage research. We've done it in some models in the laboratory using cells, and we've also started looking at it in mice with endometriosis as well. So it may be that you've been looking at. Certainly some of these drugs, if they are effective, we'd have to look at ways of giving them in low doses to reduce the side effects, or potentially delivering them by ways that they would get to the pelvis, possibly through the vagina, through a ring approach or something like that.
Thank you.
Thank you very much, and that is it for our questions. But I would like, before I ask you all to thank our panellists, I would like to just ask from our clusters of expertise here, to make sure we don't leave tonight feeling completely down and out about endo, what gives you hope? What are you hoping for in your particular area, or what are you seeing coming down the pipeline in your area that will give some hope to those clinicians who are trying to pass that microphone like nobody's business? Not me, I've got nothing. We'll come back to the clinicians, maybe, or we can get there. Yep, let's start with the scientists.
I think the amount of technology that we now have access to in order to analyse samples...
Into the mic a bit louder. Yeah.
The technology we have access to analyse samples from women, analyse gene expression, things like that, and the computer processing that we can do for what's called bioinformatics really gives us, a lot of information that we can use to address complex diseases like endometriosis. So I think that's, obviously going to give us hope for the future.
I would totally agree with what Gemma has said, but I also think there's a real there's this swell from women with endometriosis around the world, I think, and also,
it's not just endo belly. Sorry, that was a gift.
And also in the research community, we've been meeting regularly every 3 years at the World Congress of Endometriosis, and we sit down and discuss research directions, and we've become quite organised to try and make our grant applications much more attractive to the funding bodies. And then we're really starting to get to the point where we're wanting to actually do much more to ask for more specific funding from our funding bodies. And I think it's happening in Europe, and in Australia we want to try and start this process too. So I think there's this growing swell between the researchers and the women themselves that are not just going to sit back, but we're really going to do something to try and improve our knowledge of the disorder through research, and then to find the right treatments that, over and above what is available now.
Thanks, Caroline and Gemma, for science. Can I just go to the clinicians and we'll come to...
I think I'd like to get a hopeful message out. I think we have been doing a whole range of things right. We do realise that we need to build these networks of centres of excellence. We've got better imaging tools before we do surgery. My main aim for the next 5 to 10 years is to try and educate the younger generation that we have GPs and young doctors that know this stuff. And I think that's a challenge that I'm going to set myself.
Oh, good-o. Andrew?
I think what we talked about this evening is there are a number of different treatments available for women with endometriosis, but they don't always seem to work in every patient, and that could be surgery or some of the medical approaches that we've talked about. So whilst I would like to see the research that we've done in Edinburgh develop a novel treatment, I'd like to see us to be able to develop what we call a personalised medicine approach, so to be able to tell a patient when they come in which is the best treatment for them, so that they avoid having to go round and round trying different treatments. And we'll do that by bigger collaborative research projects, which we're trying to do at the moment.
And the kind of big data crunching that Gemma was talking about that makes it possible. Louise?
I think that there has been quite a change in the fact that endometriosis was quite a taboo subject. People didn't want to talk about periods, they didn't want to talk about pain, they didn't want to talk about that in a public forum. And I think it really has changed in the last 5 years or so that people are prepared to go on TV. I've tried to have things go on TV and they weren't allowed to put a uterus on TV, because it was rude. And I think that we've got much more mature about things. We're allowed to have programs in schools, and certainly I'm a Kiwi. The program there is amazing. Everyone in New Zealand knows what it is if you're under 18 because they've heard about it at school. And that dialogue means that the researchers and advocates for endometriosis can then approach politicians. The drug companies are prepared to, fund new medications, and we've had 3 new trials this year of new medications that we would hope would come on the market in the next few years. There's a lot of work going on for diagnostics, a lot of funding going into it, and a lot of it is because people are prepared to share their stories and are prepared to talk about this, and society is prepared to listen, and I think that's been quite a big difference. So that's what I'm hoping.
Kate?
Those 10 research questions that Andrew helped to develop gave me a lot of hope because they were the first in a long line to include a component on psychosocial care. So the leading clinical guideline on endometriosis doesn't include that yet either. And I think that that's really important, particularly given that, like we said before, we are a long way off probably from having a cure or effective long-term treatment for every woman. So psychosocial care is a modifiable factor that we can do to improve women's experiences now. And I think that's really important.
Fantastic. Angela?
I would just say as a patient that I'm pretty hopeful after what's come out of tonight in just the research and stuff, but that is down the path. And so for us women now that are suffering from endo and the pain that comes with it, I would just say, along with Donna, create an endo tribe around yourself, and not only that, but educate the people around you. It's not just up to the specialists to do that, but now that you know about it, educate the people around you, your family, but also other women, so that they can get the right care that they need as well.
Donna, she stole your line. Will you ever think of something else to say? I think
Like
so.
that. Our theory is start the conversation. It's up to you to start the conversation. I get in a cab with a 70-year-old guy who's driving me around and he knows all about endometriosis by the time I've got out. I don't have to say the word period once and I can explain what endometriosis is. So you got to pick your market, you know what it is that you're going to say. I may be trying on clothes in a shop and it's yellow because we know that's the colour, and they'll say, oh, that's really good, this is my charity's colour, this is why we wear yellow, and blah, 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 and I get people talking about it, oh, my sister has that, my aunt has that. So wherever you go, have the conversation, because it's up to you. I can only spread the word so far. These guys can only spread the word so far. You have to be our voice pieces as well. So you have to get rid of that taboo, get out there and have that conversation. So start the conversation. And we have done amazing things in the last 4 years. This past week, we've got our first grant that's gone out. So for Endometriosis Australia, it's only $30,000, so it's not a lot. But I've given myself the target for $50,000 next year. So each time it's going to be increasing. So I need your help by raising that awareness, and then I can raise more funds. And then we can get these guys more money to get rid of endometriosis. So I think we're well on our way, but we are the catalyst, and we're the feet on the ground. So start the conversation.
Fantastic. Thank you so much. Join me in thanking this spectacular panel. And thank you so much for coming along tonight. It would have been literally nothing without you. And I do just want to say, having been shocked and alarmed and appalled by what I've learnt in the last week, just counting them, I've had 3 conversations today with people about endo, including the poor 2 people on the plane next to me, and who happened to read what I was reading over my shoulder. So it does work, and you don't have to be an endo sufferer to start the conversation. So get your champions, and best of luck. And I'm just so sorry that things have been so bad for so long. Let's hope they do continue to get better. Thank you very much. Enjoy your evening.
I just wanna go. I just wanna go. I